Hello everyone, my name is Dr. Genia Rozen and I'm looking forward to having some really good questions tonight. This is my first Facebook Live, so it's a new experience for me, and I haven't been out of a mask for very long today, so it's a new experience seeing my face as well. So thank you. I can see there's a few of you joining now, which is great. Hope you've had your dinner or even having your dinner now. So today is all about donor conception, donor sperm, but we can go into other aspects of donor, such as donor eggs. The things that are on most people's minds at the moment, though, especially in Victoria and Melbourne, is COVID-19. We've had some high numbers today, and understandably there's a lot of concern about fertility treatment. And so I'm happy to talk about that as well. At the moment we are open, our services are definitely ongoing. We feel that reproduction, fertility treatment is something that's crucially important for people. We have a very limited reproductive lifespan, and therefore for some of us, delays are really not something that we would choose to be able to live with, and having infertility is highly distressing for us. So we want to be able to help our patients, especially those that are needing more urgent treatment, and for those that for whom putting it off is not really a great option. We are starting treatment even now, and obviously closely following the DHHS guidelines with regards to elective surgery as well. So just seeing if I missed any questions so far. So I've had a really, really busy day. It started very early in the morning, and I've seen a number of women today who have decided to start the journey on their own as single women with clinic-recruited donor sperm. It's often quite a difficult decision to make, and there's probably some of you in the audience currently that are considering having a baby with donor sperm as a single woman. And it's sometimes easier when you've had a friend, a family member, someone in your community who's done it before you, sort of the trailblazer, to be able to see how it's worked, and hopefully for them it's worked out, and giving you that confidence to be able to pursue this on your own. But it is certainly not an easy path, and we know it takes a village to raise a child. And so I see women who at the beginning of sort of that decision-making process find it really, really challenging and tricky. But once having made that decision, they find that being able to kind of be the master of their destiny in a way, having some control over the life and the choices they make, to be immensely rewarding and satisfying. And so often the positivity kind of increases as we start treatment. I'll stop my talking about this for the moment, because you can see there's lots of questions I don't want to miss. What are the options to access donor eggs, given that we can't go overseas right now? Thank you for asking that. Now, that's really, really very difficult period in our lives at the moment for those of us who need donor eggs, because at the best of times, donor eggs are extremely difficult to come by. In Australia, we have only altruistic donation, which is possible, meaning that we can't pay someone to be able to use their eggs, and therefore it takes very, very special women to go out there and donate eggs for other people. most of the egg donors are in fact known by the recipient. So it might be a family member, close friend, someone that they know through work, for example, who decides to donate an egg. But a lot of our patients don't have that option, and unfortunately go overseas as sort of a last resort to be able to access donor eggs where they are able to be bought in other countries. Now, going overseas right now because of COVID-19 is not an option, so it's increasingly become suddenly and increasingly more difficult. So what are the options? So we do have a very, very small supply of clinical recruited donor eggs through our program, and we are looking very closely at other ways of increasing our donor egg supply. For example, some of our women have frozen eggs for electively to use in the future, and have decided not to use them either because they've completed their family. That some of them do go on and actually donate their eggs to another couple, another woman, and we're exploring that sort of pathway right now. But for the majority of women, it's really, really tricky with being able to come by donor eggs. So the other way, apart from knowing someone or having someone in your life who might be willing to do that, and often the way I suggest to approach it, rather than directly asking that person, is more going the lines of sort of sharing what you're going through and seeing if they themselves sort of offer to do that for you. But if that none of those options are, there's no one like that in your life coming to mind, then advertising for a donor is possible. And within Melbourne IVF, we have the donor team who can assist with advertising for a donor and helping out that way to be able to find someone. I know some of my patients who've, let's say, had a baby with donor sperm, or who've gone through the process and understanding, the difficulties faced with trying to have a baby, especially when you need donor eggs, they've decided to donate eggs. So there's things coming up all the time. There are sort of possibilities and opportunities, but it's a really difficult time. So I hope that answer helps. So next question up. I used a clinic recruited donor last year as a solo parent, and I have an 8-month-old boy, so congratulations. That's wonderful. It's the best decision that you've ever made. And you're planning number 2. So that is really exciting. We've got 3 frozen embryos. What's the process given I already have embryos? So you're in a lucky position because you've, number one, gone through this process, so you've got some idea of what's involved from the preparation side of things. You've had success, which gives us lots of optimism for the future, having had a successful pregnancy, so that's already fantastic and a big tick. And then having 3 frozen embryos, so 3 extra opportunities without having to go through the stimulation cycle. So the process would be generally, first step being to see your fertility specialist, have a review with regards to your periods, your general health, your breastfeeding, trying to find that sort of perfect timing of when your body's ready, you're ready to start trying again. If your periods have returned and if your periods are regular, then usually we would be aiming to transfer a frozen thawed embryo in the natural cycle, and that involves doing a couple of ultrasounds as well as a few blood tests to pinpoint the exact timing of ovulation. And once we've identified the ovulation, then 5 days later, for a day 5 embryo, is when we'll be able to do the embryo transfer. So we would usually start when someone has 3 frozen embryos. Would usually start by using them. There are some exceptional circumstances where, for example, we're really keen to help and grow your family more. Someone, if they really want 3 children and want to keep those embryos for the potential of having another child in the future, we would consider doing another stimulation cycle to make some fresh embryos. But most of the time, we'll be using the embryos that are there. So good luck with that process. I hope it goes really well again for you. So next question, can you please explain the process of using donor eggs, how to find a suitable donor? So we've addressed finding a suitable egg donor, which is really, really difficult, but there are possibilities, and we're happy to help with that. How to use the donor egg. So when you're a couple, and so in other words there's a male partner involved, then we would be aiming to use the partner's sperm to fertilise the eggs. So when an egg is frozen and thawed or warmed, we would always be using the fertilisation process called ICSI, intracytoplasmic sperm injection. So directly injecting the sperm inside the egg. Because the way the egg is frozen, the outside cells, the humulus is dissected off. We don't just put the sperm together with the egg, but rather inject the sperm directly in. In fact, that's kind of what most people think of when they think of IVF. They imagine sort of that needle with the tiny microscopic sperm piercing the outer shell of the egg and the sperm being inserted inside the egg. So that's the fertilisation of how we would be aiming to create embryos. And then the female, so the cycle, using, for example, the natural cycle or medicated cycle, after the egg is fertilised on day 5 following ovulation, we would be aiming to transfer that embryo. So an embryo that's from the egg that's fertilised, and 5 days later developed into a healthy, nice-looking blastocyst. So, and transferring an embryo like that, the success rate of it is very much dependent on the age of the egg donor. So with an egg donor under the age of 35, with having a blastocyst day 5 embryo transfer, the chance of success is upward of about 40%. So really, really good success rate. So often, we're using we're using donor eggs. It's because of a lack of success with IVF, and it's really very, very satisfying to be able to take a couple who's been having a lot of problems getting pregnant and relatively low chance of success, and suddenly being able to give them that really high chance of success is amazing and extremely satisfying. So I'm going to move to the next question. Thank you so much for your interest and asking lots of questions. Do you know how many donors are on the ICSI list? So thank you for that. Great question. I don't know the answer, and that's because the answer is changing constantly. It's a dynamic list. Melbourne IVF we don't have a sperm donor waiting list, which means that it is a very, very dynamic sort of situation where the donor would be picked out, so snapped up. Other donors will be cleared because obviously there's the quarantine from the donor. So sperm is collected, but then it's frozen for a period of at least 3 months, after which time the donor is rechecked for infectious diseases. So there are sperm or new donors that whose sperm is being released from quarantine continuously, and so some donors are taken, new donors come in, and it's a constantly sort of changing the dynamic process. I tell my patients, for example, if they've looked at the donor list and there's no one that they really gel with, there's no one that fits their bill, and that they connect with, they might just want to wait a little bit of time, and new donors will enter the playing field. So that's kind of a very long way of saying I don't know, but if the sort of numbers that we see on the list for ICSI, and I'll explain what the other option, what the other list is upward of about 40. Sometimes there's 70, but those are the sorts of numbers that we hear about. So there are some donors that are suitable for ICSI, so the sperm when it's thawed needs to be injected directly into the egg. There are other donors with a very, very high concentration, for example, of sperm in their ejaculate, who are suitable for IUI or insemination. And that list is usually a little bit shorter than the ICSI list. So, is there currently a waiting list for donor sperm? No, there is no waiting list, and it is a dynamic sort of list. And how long is the process from registration to being able to access donor sperm? So, the time from registering to being able to see the donor list usually should be within about 4 to 6 weeks, I think. And then after that, the start of treatment really depends on your cycle, because, for example, you've done all your appointments, the two donor team appointments, appointment with the counsellors, the nurses, and the admin, and you're ready to go. But, for example, you might be halfway through your cycle and waiting for your next day one, so that obviously adds another 2 weeks until when you can start. So the starting dates are very much dependent on your cycle. What happens if the donor has 10 children and embryos are frozen? Do they have to be destroyed? So it's 10 families that one donor can help create. So currently 10 different women, offspring of 10 different women. So in my experience, we would never be destroying embryos. I think it would be a bit of a discussion at that point, because also, if the donor's getting towards that limit, there would be a discussion prior to creating additional embryos as well. We'd never want to be in that kind of situation. So what about someone who has a balanced translocation and struggling to get PGT tested embryos with own eggs? So when one of the reasons that we do IVF, apart from some of the obvious reasons to do with infertility, is actually if there is if one of the couple, for example, or both are carrying a genetic problem, so that's what's called monogenic pre-implantation genetic diagnosis. So there's a genetic disorder, single gene disorder that we're trying to avoid passing on to the offspring, and that would be a reason to do IVF, even in the absence of any fertility issue. Another such circumstance, if there is a chromosomal problem, so this is what this question alludes to. So you could have chromosomes, going one step back, chromosomes are packages that house our genes, our DNA, and I might have the right genetic material and all the right material that the packages contain, but one of the half of my chromosome may be stuck onto another one, and therefore when the chromosomes separate to create a single copy for my egg, because of course my egg and the male sperm has only one copy of the chromosomes, that split can be uneven and unbalanced. So that would be another reason to do IVF, to create embryos which are then tested or biopsied at the day 5 stage, to only be transferring an embryo that has all the right complement of chromosomes. So sometimes even in a couple like that, without the infertility history, there's still sometimes not an easy road to get them pregnant. Sometimes we may have, for example, a lot of ovarian reserve, which means that we only get a few eggs each time, and so we only get a few embryos, and all the embryos might be carrying that genetic problem, and therefore we might have no embryos available to actually use. So struggling to get the testing embryos with own eggs, what are the rules for a donor friend? So that so I think that question relates to donor egg, and certainly that would be an option, using donor eggs. And when someone is interested in bringing an egg donor to the clinic, it's called a recipient recruited donor as opposed to the clinical recruited donor. We would always be seeing them. They would be seen initially by one of us, one of the fertility specialists, and then have follow-up with the donor team, nurses, etc. So that would certainly be an option. In terms of age, there is no specific cutoff, though we would ideally prefer, because success with IVF is very much always dependent on female age with other circumstances. So we would always like a younger donor, so someone who is around or below the age of 35. But there are women who are highly fertile in their later 30s. That we would still, if there are an option, we would definitely still be accepting of that. We would really like for them to be under 40, because we know that even the most fertile of women above who are getting older and above the age of 40 would have a significantly reduced chance to succeed. We know that I think maybe a good option to digress and talk a little bit about age. I think it's something that that we are learning, that the message I think is getting out there more now about how important age is. But even so, we know that when we speak to some of our patients, there's some questionnaires that we see the results of, still people do have beliefs that perhaps we are more fertile as we get older than we really are. So there's a thinking amongst men and women that we are perhaps, let's say in our later 30s and 40s actually are more fertile than we really are. And also a belief that fertility treatment or assisted reproduction can help when there is a problem with infertility, even for older women. And that's kind of different to the reality that we see, in fact, where both natural fertility and that with IVF is hugely dependent on age. And that's where, because we know that the age of having the first baby has gone up a lot. We know that as a society, women are taking more, women are getting more educated and able to work on their careers. Not everyone wants to have babies in their 20s, for example, or even early 30s, and that's a realistic choice that we can make these days. But our biology hasn't really changed. A few generations where we've changed what we do. Our biology sort of hasn't caught up with the program, and we're still lag behind. We still, our most fertile years are in our 20s, and the very, very early 30s. And so there are thankfully more options now, that there are some other opportunities for those of us making those choices and wanting to start our families a bit later in life, such as what I alluded to there is egg freezing or elective egg freezing. So we know that there's a huge problem, for example, with the far more women needing donor eggs than those that are available, and that's hopefully, in some time, in years to come, maybe less of an issue if more women actually do decide to freeze their eggs, because then it's like, for example, a woman who freezes her eggs in her early 30s, who then decides to use them in her late 30s, is a little bit like her own egg donor to some degree, and they find that the process is not as arduous as it otherwise would have been, and that she might be able to have more children than she would otherwise be able to, and be able to have more a chance to complete her family. So the age is something that we think about and that we talk about a lot. And unlike, for example, pregnancy complications, so for a woman in her 40s, for example, who's very fit and very healthy, her risk of pregnancy complications such as preeclampsia, gestational diabetes, etc., those are very much mitigated and reduced by the fact that she's healthy, and there's still a really good chance of having an uncomplicated, healthy pregnancy. However, fortunately, we can't say the same of the eggs. They age regardless of our fitness and health status. So the other part of that question, before I digressed, if they're interstate, so if an egg donor is interstate, we can we should still be able to organise treatment, and we're able to transport gametes from across states, and we can do that quite successfully. Do you do a cycle of IVF and fertilise fresh eggs and sperm just like a normal cycle? Yeah, so there would be, if we're using a donor from interstate, we would have the option of freezing eggs, for example, interstate, and transporting the frozen eggs to us for warming and injecting the sperm. Alternatively, if we've frozen sperm, we can transport the sperm across interstate to thaw it and inject it to the eggs, but then we'd have to get the embryos back, so that would involve two sort of interstate travels. So ideally the eggs are brought to us, warmed, injected with the sperm, and the embryos created, and it would be biopsy at the day 5 stage and then frozen. But there's a few different options about how to do that. So we've got a question, someone for whom this is all still very new, and that's in fact lots of people. 2 children, single mum, 36 years old and considering a third. It's fantastic. If I wanted to begin egg freezing process, can I do this now during lockdown restrictions? And can you explain the process a bit more, including costs? So, so we know that for someone, let's say, who it's not uncommon for us to see someone who has a child or even a couple of children, and say who might be in a new relationship or has separated from a partner, who doesn't want to give up on the idea of having more children in the future, but the circumstances in that person's life is that it's not an option in the near future. So that's where egg freezing can be very useful, because we know, especially in that sort of the other side of 35, that things increasingly year by year become more difficult. And so if someone was to freeze eggs at 36, we expect a chance of success with those eggs after they're warmed or thawed, to be, even if that happens few years later, even 3, 4, etc., sort of unlimited years later, to be the same as those 36-year-old eggs. So in terms of the chance of live birth and also the chance of miscarriage, because of course we know that goes up with our age as well. So freezing eggs can give that opportunity in the future to have another baby, a third child, and it can be the difference between sort of having that chance and not. Of course, freezing doesn't guarantee success with those eggs. It's not, it can't be thought of as a really foolproof insurance policy. You don't want to put plans on the back burner just because you've got those eggs there thinking that there's a baby there, because we know that some women are not going to have success with those eggs. But if, as I said, if it's an option between doing nothing, hoping for the best, or freezing eggs, then egg freezing is certainly a viable option and can give those extra opportunities to have, in this particular case, a third child. In terms of the current restrictions, how does that affect elective egg freezing? So there is a directive from DHHS to reduce our elective operating, and within Melbourne IVF, we've found a number of ways to do that in our day hospital. But with regards to our fertility, for those women who are wanting to electively freeze their eggs and they are young, so under the age of 35, with a really great ovarian result, so they're a really good prognosis group for whom a delay of a month or 2 or 3 is very unlikely to cause any reduction in their overall chances. They're the women that would be trying to delay in order to comply with the restrictions, and the idea behind it is to sort of reduce the exposure of people, reduce the number of patients that healthcare workers are coming into contact with, etc. So, but for someone who, for example, is 36 and wanting to electively freeze their eggs, currently there is an opportunity to do so, but things in that sense are changing literally on a daily basis, and we can keep you updated. So in terms of explaining the process, essentially you would all start once again with seeing a fertility specialist. There are different ways to find one of us. We have there's a few of us who have slightly different interests. We operate out of different locations. We speak different languages for whom that's relevant, and we can find out some information about the different specialists on the Melbourne IVF website. And so it starts off with seeing one of us. We will go through the treatment, the possibilities, of course, exploring the medical history, gynecological history, etc. We would do some pre-pregnancy testing, assessment of your ovarian function, reserve, and then put you in touch with the admin person, the PLA, patient liaison administrator, who would organise some appointments with the nurses, the counsellors, and those appointments can be done quite quickly if you're wanting to start a cycle as soon as possible. They will go through all the cost side of things as well. Essentially, it's about $5,000 for elective egg freezing, where there's no medical indication, plus the cost of the medications. And then you'd be able to start with a cycle. Sometimes, depending on the situation, we can also do random start within the menstrual cycle when we're doing egg freezing, because we're not trying to sort of line up where the development of the eggs or follicles with the development of the lining of the uterus. So, next question, is it a good chance of pregnancy with embryo grade 5AA and FET, so that's a frozen embryo transfer cycle? So, the pieces of information we have in that question, so good chance of pregnancy. So first of all, maybe I'll talk a little bit about what we consider a good chance of pregnancy in general. So the context, and sometimes when I talk to my patients about what their chance of pregnancy is with a day 5 embryo, I like to kind of precede it with the background of pregnancy. As a sort of a species, as humans are not the most fertile. We're not great breeders, unlike mice and rabbits, for example. So even the most fit and fertile of us, the youngest, most reproductively fit ideal couples, have about a 20-25% chance of conceiving per cycle. So this information comes from population studies where contraception is not used, and it's analysed how many children these sorts of communities end up having. And in fact, may surprise some of you that the chance of conceiving per cycle is about 20-25% in the best of couples and the best of hands. So when we look at a success of, let's say, 20% or 30% from an embryo transfer within the context of IVF, while there's a high chance of not conceiving in that cycle, we see that 70-80% compared to conceiving. That's actually a really big win in some ways, because you're taking usually an infertile couple and giving them a similar or better chance than what the most fertile couples would have. And that's the context of how we frame when we're talking about any success rates. But the question was about a grade 5A embryo in a frozen transfer. So it might surprise you that even when you know the morphology or grading of an embryo, it's still, a lot of it really comes down to age. So to answer roughly the chance of success with that sort of embryo, I'd need to know the age of the female. But let's say if the age is between 30 and 35, then that embryo, 5AA, in a frozen natural cycle, would have about a 40, upward of 40% chance of pregnancy, and just a bit less than that of live birth, because we expect the usual miscarriage risk, which is not as high when we're talking about a woman who's 32, let's say. So I would say that's an excellent chance, about 40% chance of pregnancy. But even so, it's really important to consider the fact that it's still similar to flipping the coin about whether that cycle works or not. And that's where, the journey of it comes in, that it's not a one-stop shop. We do get lucky, we get pregnant first go, but it's really much more helpful to think about it in terms of starting a journey and not expecting it to be successful straight away. And then if it is, it's a wonderful surprise. So success rate of pregnancy using frozen eggs. So the success rate, the way that I explain it to my patients is that for women who freeze their eggs, who let's say under 35, under the age of 35 when they froze their eggs, and about a 85 to 90% chance, have 85 to 90% survival of their eggs once they're warm. So in other words, about 9 out of 10 eggs will survive that process of the warm. And then after that, they actually seem to behave the same as fresh eggs with regards to all the rest of the downstream sort of processes. So the fertilization rate, what's called blastulation rate, or in other words, the number of day 5 embryos created from those eggs, and then the chances of each of those day 5 embryos implanting seems to be the same as fresh eggs. So we expect to lose about 1 in 10 eggs in that process, but after that the results are pretty much the same as if you were using fresh eggs. And so, for example, if you were under, between 30 and 35 when you froze your eggs, and you've got about 15 to 20 eggs in the bank, then you would have an over 80% chance of a live birth with those frozen eggs. So, and that seems to be, for our, we've now seen quite a few women coming back to use their eggs, and that seems to be the sort of worldwide experience in the publications that we have seen to, in our practice, support that. So the really important things to take out of it is, number one, the more eggs we have frozen, the better odds we have. And because there's so much we don't know, because of course it's not just about the eggs, it's then about the sperm as well, ultimately, that is used, and lots of other factors. But the chances overall are excellent of having a pregnancy if you've got 15 to 20 eggs under the age of 35. But the other side of it is that it's not something that every woman is going to be successful with. So I think to avoid future disappointments, it's really, really important to have the correct, accurate expectations to begin with. And I very much emphasise to my patients the no guarantee aspect of this, and so not to sort of put off having a baby or trying naturally or whatever it may be, because you've got frozen eggs, keeping that still very much at the forefront of your wishes and your plans, and then obviously reality and real life gets in the way, and fertility is for most people not the only thing that they're considering. The other thing that I was going to say something else about using frozen eggs. Yeah, the other really important aspect to remember is that so far in the worldwide experience of elective egg freezing, most women actually do not come back to use their eggs. And that's important for anyone considering doing this, that so far statistically you're doing this to have that option, to have those additional opportunities available, but you're not actually expecting that you will definitely come back to use them. And I see that as something that's actually quite positive, that some women at least would not come back to use their eggs because plan A's worked out. So perhaps they've met that partner, they've tried naturally, and it's worked out. And that would always be, you'll always try naturally before coming back to use the frozen eggs. I also see that as potentially something that will change in the future, because if, let's say, plan A, you're 37 or 38, when you have met your partner and you're wanting to get pregnant and you have had success, and you haven't come back to use those eggs, that might actually change, because a few years later you might decide that you actually do want to have a second child, and that remains a realistic option for you if you've got the frozen eggs at your disposal. And so perhaps we still haven't seen some women who will come back to use those frozen eggs who haven't done it yet. I hope we get to all your questions, because there's so many of them. Is there any movement in Australia on mitochondrial DNA transfer from a donor? There's a larger trial in Greece, but curious about any local considerations. It's not something that I think I'm not aware of any trials being done locally. It is sort of, it's a bit more than pie in the sky, but there are a lot of considerations, and so I think we're very far from it being a realistic possibility here in Australia. Can you still get a Medicare rebate for egg donor cycles? So yes, if there is a medical indication for having fertility treatment for you, so I'm not sure if I've got the names right, but if you, for example, have balanced translocation and that's a reason for your fertility treatment, then there's a Medicare rebate for the egg donor as well. So one of our listeners here, there's an appointment tomorrow, and wanting to know if they can bring their 7-year-old due to the restrictions. I think it would be best to check with the clinic, but our preference very much at the moment is to reduce contact with anyone that is not entirely is not who doesn't have to be at the appointment, who's not an absolute must. So I'm not really seeing any children currently, and I think that very much it would be advisable not to bring anyone else to the appointment. Another question about Porter-Equino syndrome. So that's a spinal cord issue that can cause erectile dysfunction. So there are options about how to be able to get sperm from someone that has a spinal cord issue and is not able to either, if there's a problem with erection or with ejaculation as a result of the spinal cord issue. The sort of things that are possible are under anaesthetic to be able to, a urologist would usually do this procedure to be able to stimulate and get the sperm production that way. Sometimes that involves a prostate gland stimulation. The other way of getting sperm is directly from the testicle itself. So yeah, there are a number of options in that situation, and I think the doctor that you're consulting with tomorrow would be able to definitely guide you expertly through the possibilities. So that should be something, that's a really, really treatable reason for not being able to conceive. Let me have a look. So someone who has a high-grade embryo, so nice embryo, but had a failed transfer and very heartbroken as a result, and who's 36. So, I guess thank you for asking that question. It's kind of the sort of situation that I was describing before, where there's an excellent chance of success, even though you're 36, there's still about 30 to 40% chance of such an embryo implanting and having a clinical pregnancy. But you might have your hopes up because those chances are quite good. But on the other hand, if you look at it, it's still a little bit less chance that even tossing a coin. So the fact that the first one failed, well, that is really can be very distressing and disturbing, and there's no other way to sort of I think deal with that, but to acknowledge how upsetting a failure that is. On the other hand, it doesn't actually point to any issue. It doesn't mean that we're any less positive or optimistic for ultimately this treatment working for you. And it's really about getting those extra chances, improving probability. While we don't expect to get to roll a number 6, for example, when we die the first time we try, let's say if we're trying to get a 5 or a 6, we don't expect to get that the first time. We expect to have to roll that die a number of times before getting the number we want. And it's the same, I think that's a good analogy to keep in mind, that while we may have a number of roles that don't give us the result we want, we're increasing our chances ultimately that we will get to those numbers. The more times we do it, the more overall chance we have of getting the numbers that we want. So I think doing the right thing, staying positive for your next transfer, because there's absolutely a great chance. And if you don't get there the second time, doing it again, you're still going to have a greater chance for you. The reason, what is the reason why embryos don't take? So there are lots of reasons actually. And in fact, in some ways, it's there's so many things that have to actually line up and work perfectly well together. That it's not surprising that lots of embryos don't take. The major things that we can describe are, number one, the chromosomes of the embryo. So that's what I described before, those packages that have our genes. They have to be right, and a lot of embryos, especially as we get older, a lot of the embryos that we make actually don't have those those chromosomes being normal in terms of the number that they have. Sometimes the number of chromosomes can be normal, but the actual genetics within that embryo, DNA, is not entirely normal. So those would be the causes that are related to the embryo itself for the transfer not working. And then there are causes related to the uterus, to the lining, so that the uterus has to be, the lining has to be receptive. They have to be able to sort of talk to each other, to be up to the same point of development. And then there's all, other things such as immunity. The body has to have an immune response to help with presentation, but not have an overwhelming immune response of sort of fighting or not accepting the embryo. And sometimes things, for example, endometriosis is a cause. So that's endometriosis is when the lining that normally sheds on every period, and that's found in plants somewhere in the pelvis. And we know that that's not uncommon at all, especially for women with infertility. And we know that sometimes those deposits of endometriosis can secrete cytokines and inflammatory factors that may be hostile to that embryo and may reduce the chance of that embryo implanting. So there's all these sort of, apart from the embryo and the uterus, there's also other sort of smaller ticket items that contribute to an embryo not implanting. But ultimately, I think for you, the listener who's asked this question, to keep at the forefront of your mind is that there's still an excellent chance of success, that you're just sort of at the beginning of that journey, and that there's every chance that you'll get there in the next few transfers or rolls of the dice. So there's been some excellent questions tonight. I think everyone who's joined us, I think it's probably a good time to wrap things up, just in case I get more questions that I won't have time to answer a bit later. It's really great to have the opportunity to talk to you when you're comfortably in your own homes, and sometimes when we've done these information nights in the past, it takes a lot of energy to leave home at night to come and listen to us, whereas this feels like such a great forum and platform to be able to talk to you. It's really important that while we can answer your individual questions, that you remember that any of us who are doing these sessions, we don't know your individual circumstances, and they're really important to be able to guide you. So your specialist will be the one who will be able to give you the most individual information that's relevant to you, and that these sort of answers that we give are somewhat of a general nature without knowing all the ins and outs about you. Because we have to remember how different we all are, and treatment that for a similar sounding problem may be completely different for someone because of their individual needs and circumstances. But yeah, thank you for all the questions and your enthusiasm, and I will perhaps see some of you later.